Perfect. Good morning, everybody, and welcome to Cardiology Grand Rounds. It's an absolute pleasure and honor to introduce my close friend and colleague, Dr. Burkhard Mackensen. Just briefly about Burkhard, he did the majority of his training in Germany, predominantly in Munich, and then came to the United States in 2009 and worked at Duke doing research, and ultimately became a faculty member at Duke. We were fortunate enough to get him here to the Northwest in 2012 when he became the chief of CT anesthesia. And at that time, he actually advanced a little bit, or quite a bit, and became the acting chair of anesthesia for over 2 years, from 2012 to 2014. In 2014, I actually arrived and I had the opportunity to meet Burkhard. And with his interest in imaging and my colleagues in cardiology, we were able to really create a great collaboration over the years in structural heart disease. I think some important features also about Dr. Mackensen is that looking at a CV, obviously is published extensively, but really one of the features of the CV that really struck me is a long list of young faculty members in anesthesia that he lists that he's mentored. But frankly, I think that list extends beyond what he has in his CV and includes a lot of the cardiologists, a lot of other folks throughout the country who's had a significant effect in guiding, in teaching, in 3D imaging and TEE. He presently is the interim chair of the anesthesia department again. So like everything in life, it's like a big circle. And I'm absolutely delighted to have him present to the Cardiology Grand Rounds today. Dr. Mackensen.
Thank you. Can you hear me already?
Perfect, yes.
Perfect. Good. Well, thank you, Mark, for that kind introduction. It's a great pleasure to have an opportunity today to share with you what I called, with Mark's help, procedural image guidance or image-guided therapy. In this case, image-guided therapy for structural heart disease. I don't have a real disclosure relevant for the talk, but I would like to disclose that we recently, as you probably saw in your newsletter, achieved quite a milestone in having as a team that includes many more people besides the two pictured here. As a team, we treated 500 patients with the MitraClip therapy, the edge-to-edge therapy to reduce mitral regurgitation. That's, for an academic medical center, a huge achievement. And I don't think there's actually, frankly, another medical center academically in the US that has reached that. Now, we have come a long way. And when we start on the left with open heart valve replacements that look like a ball and cage, and we then think about open heart valve repairs that are much more minimal invasive already and can potentially be done through port access, we then also can consider minimal invasive surgery approaches or transcatheter approaches, as you see here, through the apex of the heart. And at that point, we start actually thinking about no longer needing the heart-lung machine. Now, on the far right, when we talk about percutaneous approaches to mitral valve repair or potentially replacement, then we no longer need the heart-lung machine and have achieved an opportunity to keep the patient much shorter in the hospital, be much less invasive, produce much more pain, much less pain, and have just a much shorter hospital stay altogether. Now, with the advent of all these minimal invasive techniques, be it surgical or interventional, we've also seen a huge rise in the need to help with image guidance. Now, where the surgeon can look at the open heart and do the repair that way, or use a robot in order to see what she or he needs to see, for minimal invasive surgery or percutaneous approaches, there's much more reliance on the imaging. Now, quickly wanted to review, without going into too much detail, that to date, more than 100,000 patients worldwide have been treated with the MitraClip therapy, which is that edge-to-edge repair. More than 4,500 patients have been enrolled in clinical trials. And while the first case of a mitral edge-to-edge repair was done in 2003, I think it's this hallmark or this year of 2007 where really everything changed. The technology of the MitraClip therapy, even though advanced much further since 2007, has not nearly as advanced as much as imaging has. And imaging has advanced mostly based on the technology that has been introduced starting in 2007, now competitively by numerous vendors, giving us an opportunity to image the heart, not just in 2 dimensions, but also in 3-dimensional approaches, as well as use multiplane or biplane imaging. I'm going to glance over the next steps real quick, but just suffice it to say that the technology for the MitraClip has really evolved, and that also the FDA approval for the device has gained a lot of traction, first for degenerative disease, and then finally for functional mitral regurgitation. Now, November 2019, we, as other 20 centers in the US, were fortunate enough to be first to get the 4th generation MitraClip device, which I'll speak about in a little bit. Now, here is a landmark study that I just wanted to bring up to our memory, even though many of you probably have not only read the paper, but really thought about the findings quite detailed. The key finding here, extending to a 3-year mark, shows that both all-cause mortality or heart failure hospitalization were remarkably impacted if you add the MitraClip device as a therapeutic addition to a patient who already has a goal-directed medical therapy that is optimized. And these types of Kaplan-Meier curves, we may have only seen with penicillin or similar interventions of magnitude. I wanted to take one moment to speak to one of the key considerations that I think is important for us to understand. The MitraClip therapy is not the Alfieri stitch, even though it mimics perhaps what Dr. Alfieri first thought of when he introduced the Alfieri stitch as a method to add to his portfolio, if you will, for MitraClip surgery, mitral valve surgery as a repair. He actually didn't even start with A2, P2. He actually started treating more of the commissural disease. But on the right-hand side, what you see remarkably is the MitraClip therapy is so different in that not only do we do the therapy and the repair on a beating heart, no, we also actually are in a position to monitor the effect of the therapy and look at numerous parameters, including the change of mitral regurgitation in front of our eyes, as well as hemodynamic changes. We can always reposition that we have available to really cater to the needs of a particular pathology of a patient. I brought up this slide from a review article that we submitted a couple of years ago, just to remind myself and you that even though the challenging morphology in the middle was something that we were not treating up front, we were mostly playing on the left-hand side of the slide, we now actually even have gone beyond the challenging morphology and start even at times treating some of the so-called more unsuitable or even more challenging pathology. I think that's important to keep in mind. This is just a list, a cookbook list or a procedural step list that I will just briefly go through. And I apologize if I go quickly for some. Those more familiar will be easily following. Essentially, we start with a comprehensive assessment, and I'm going to get right into that here in a moment. Before that, I want to highlight the fact that any pre-procedural image, be it transthoracic or be it transesophageal, needs to be as good as possible for us as a team, as a structural heart team, to be able to make a decision about the etiology of MR, understand the morphology, the mechanism that causes the MR, and then to come up with a procedural plan. Also important is to quantify the mitral regurgitation based on 2D and 3D methods, and ultimately really identifying the opportunity for treatment or the exclusion of a patient for a given device or therapy. I would also like to highlight that it's very important to work with biplane and 3D imaging in order to prepare the patient for the right device selection, and then ultimately have a high quality 3D image that allows post-procedural imaging and analysis. I've put this together as a reminder of the Carpentier classification for mitral regurgitation. And while probably most of us are not ever really in a position to remember this classification, and therefore it may not be as applicable in our day-to-day clinical practice, it still organizes our thoughts. And so if you think about the Carpentier 1, type 2, and type 3, we really can go through systematically. And I found in our collection examples for each of these, even though some instances, some etiologies are not as common. For instance, a perforation of an A2 scallop you won't find on a regular basis. Now, this is the reminder again about the high quality 3D image. When I first came, I negotiated for TomTech software to be installed within a year of my arrival in 2012. Unfortunately, sometimes the very good things take a long time. It took 7, 8 years, actually. Coincidentally, just as COVID hit, we had the installation of TomTech software. And here you see a quick example of a dynamic 3D model that I was able to obtain, or create, better to say, as a post-processing analysis based on a meaningful 3D data set. So please, if you have opportunity, be involved in pre-procedural imaging. Whenever you can, try to achieve a high quality 3D data set. That opens the door for so many further analysis and thoughts and considerations. Again, as I outlined in my one slide, it's critical to have a good baseline severity assessment of mitral regurgitation, and also look at the dimensions of the valve, use methods such as PISA or multiplanar assessment cropping into the mitral regurgitation to really be in a position to assess quantitatively how big the vena contracta area might be, as you see in the center of the slide. What has also now been possible, and this is really the newest iteration of some of the software that we have seen over the last couple of years, but even not yet the ultimately newest version that is even further advanced. But what I'm showing you here is not QLab. It is not a software built in where you have to kind of get out of your imaging. This is actually on-cart live multiplanar imaging. And as you may see in this left half of my slide, I use the red plane with the dotted line and then the corresponding upper active frame with the yellow arrow to really look at the line of malcoaptation, or better to say, look at the posterior P1 prolapse, how it may correspond with the anterior leaflet and how that may become a treatment option for the mitral valve therapy with the MitraClip as an edge-to-edge. And the red plane really helps me to orientate the clip in a fashion that we can come up with procedural planning. And I can share this with Mark before we actually start and say, look, this is how I think you need to come in with the clip, and you see the result on the right-hand side, where then in that particular patient, we exactly followed that approach that we had come up with in the beginning, orientated the clip, if you will, in a 2 o'clock, 8 o'clock orientation, and got a very good result, basically eliminating the entire prolapse with just one large clip. Here is a little bit of an overview of the newest generation of MitraClips. There's now 4 sizes, as I said. There's larger ones and smaller ones, and there's wider and more narrow. So really allowing a bit of a catered or tailored better to say, approach to whatever we need in whichever situation. And as you can imagine, if the grasping area of the clip becomes wider, there is opportunity to pull in more tissue and maybe be more efficient with one clip, and maybe also not using as many clips for a given procedure. Of importance, you need a long enough leaflet in order to use the larger clips, and we'll come back to that in a moment. There's a few additional changes with this newer technology. I'll not spend too much time on it, but I wanted to point out the second item, which is that controlled gripper actuation, which basically means we can grasp on one side only, maybe get the posterior leaflet first and then go over to the anterior or vice versa. I'll show that on the next couple of slides here in a moment. Before I do so, I also wanted to display some of the results of our initial work with this new generation MitraClip, where on the left-hand side, you see a collaborative effort within the first several months of our experience with the Generation 4 mitral valve system for the edge-to-edge therapy. And you see we have had a mix of cases where we treated both primary and secondary MR and used a variety of these clips indicated with the different colors, certainly using the larger and wider clip the most. And then next to it in red or pink, it is the wider but shorter clips. Those are our two workhorse clips at this point. This collaboration is with a site in Texas at the University of Texas, and we have submitted this currently to Eurointervention as our first experience. In Europe, the centers are in the process of also rolling out Generation 4 MitraClip therapy as a new step. On the right-hand side, you see, and I again have no time to go into much detail, but you see what we, as part of that publication, have come up with in terms of suggestions for optimal use of these 4 different clips. It can get a little bit confusing. There's a few caveats. I'll give you one example. Obviously, if the valve is narrow and if there's lots of calcification and maybe there's calcifications in the cords, we want to be careful with using a large clip that can easily be entangled in the cords. Our third step for the procedure is to find the optimal space or spot for actually coming across the septum. So we're coming up from the groin. That's Dr. Riesman coming up with the catheter and the needle in order to provide a tenting indication of where he's about to cross the septum. And then we're using inferior and superior as well as anterior and posterior dimensionalities in order to really find the optimal spot. Ideally, we are at a certain height above the annulus, and we can see this in 3D or in 2D. I'll come back to that here in a moment. For the trainees, I think it's important to always think about what can the echo actually help me doing. I can anticipate what I want to image next. I can anticipate what's going to happen if I turn my probe a certain way. And these next 2 slides or images here will actually do that for you. Starting with the bicable, just simply turning the probe left gets you into a long axis of the aortic valve. You then go beyond that and you start seeing the mitral valve anterior leaflet. And in the end, you're actually all the way over to what could be then the pulmonary artery. There you see it at the end. We can do the same thing in the live 3D, basically reinforce our education. Aortic valve, I'm turning further. Now I see the PA and the left appendage actually in the background. Again, bicable, aortic valve, turning further. I'm now looking in a moment here into the pulmonary artery and then the left appendage. So I can anticipate what's going to happen with a certain manipulation of the probe. Now, we use, as I indicated already, multiple views, often biplane imaging or corresponding 3D imaging to find the optimal spot. Again, I don't have too much time going into detail, but here you see a tent on the right-hand side quite nicely in the aortic short axis view, and we then coming across. To illustrate the difficulty that we have, we at times have gone to the cadaveric specimen in our cardiovascular innovation center with the help of Dimitri Levin, have then come up with a simulation where we essentially have a TEE, fluoroscopy, and a live in-heart camera that then indicates the needle and the contact that the needle makes. So here, Mark is pushing the needle up towards the septum. We see it in the echo. At the same time, I can then use a biplane imaging now and put the tilt plane right into that spot, and that therefore indicate on the inverted short axis on the right-hand side the intent or the proposed puncture site. Very helpful to go through these types of simulations, as you can imagine. Now, the transseptal puncture can be made quite complex if you think of all the different procedures for which a particular height coming across might be ideal. Suffice it to say that this part of the procedure sets up a successful MitraClip intervention. I can share that with you. So in order to help that, unfortunately this didn't play, I'm going to go back. In order to help that, you see here the tenting indicated with the red arrow. And then for orientation, the IVC and the SVC. So really important to know where we are, which position we have. And in order to be precise, I can use a cropping plane in order to crop into the annulus and the tenting spot, and then do a 2-point measurement for the perfect height. Now, once we are across, we can actually start moving the guide delivery system across as well. You see that here, both from a cadaveric situation as well as an en-face view now with a 3D image indicating the position of the guide across and then above the posterior medial commissure of the mitral valve. Now, for further imaging, we can use live 3D imaging, as you see it here. The guide, or in this case, the valve, the wire itself or the catheters can be seen quite well. Sometimes it takes just a slight movement of a wire for us to actually pick it up and see it on echo. So again, communication is key with the interventional cardiologist. Now, this next slide shows you how we actually then quickly are diving down to the valve. And if we can set up a larger 3D volume, like I'm showing here, then it's most convenient for both the interventionalist as well as the imager to really have confidence that we are within the confines of the left atrium, that we're navigating the ligament of Marshall, we're not going into the left atrial appendage, and so forth. So here I'm showing a stepwise steering down to the valve, and you see how the clip very nicely is being steered down just to be above the valve. Certainly we don't want to be inside of the valve right away. Now the clip is being opened. We can see it here from the side, and then we can start working on perpendicularity, meaning lining it up such that it is perfectly aligned with both anterior and posterior leaflet. To illustrate that again in some stills, here's the cadaveric situation. You see en face how the clip can be rotated. And then finally, from the position above the valve, we can then go inside the valve, either with the clip closed or open. And then with reducing the gain on the 3D echo, we are then able to, again, see the clip and its orientation and then optimize the perpendicularity, just exactly how we set it up or planned. Now, I spoke about the controlled gripper actuation, which is the opportunity to grasp one leaflet first and then get the other, which in a large gap is very helpful. Here you see the gripper waving at us. That's just a test before we go in the valve in order to be certain which gripper is which on the handle on the device. I'm pointing out in a still what you're about to see in a moving 2D image, that there's the anterior gripper on the right-hand side. So the anterior leaflet is to our right, the posterior leaflet is to the left, and the posterior gripper will at first be up and then come down to engage on this moving clip. Here you see it. So the anterior gripper is already dancing on the anterior leaflet, and the posterior leaflet is about to engage with the clip arm. And now the gripper just came down to then, in the second step, capture that posterior leaflet. The clip is not closed yet at this point. At this point, the interventionalist will close the clip just ever so slightly, You see the whole loop playing one more time. This really has been a great addition in desperate situations where we can't quite reach. Certainly, this approach is also being used with caution, because you can imagine if you pull too much on one end, you may actually cause more harm than good, unless you're really watching what is happening. Again, making imaging crucial in order to pick up any tension or even a torsion or some additional stress on the leaflets, especially if the rotation of the clip changes while we get one leaflet before we get the other. To show now under number 9 that we now have had a grasp, we still are on the valve, so both grippers are down. The clip now has been closed, and we can start to assess the situation both for the insertion of the clip as well as the reduction of MR. On the left-hand side, you see an en-face view with a large lateral opening, but still an indication of a figure 8. There's also of note some dropout that you see towards the posterior medial commissure. On the right-hand side, it's the utility of biplane imaging with a precise location of a tilt that helps us to illustrate the right side image. Now, color compare is often helpful. Here we see a situation with actually 2 clips to assess the result. And then the multiplane imaging that I talked about up first shows, again, a figure 8 in the short axis and in the 3D en-face view. I want to take one moment to speak to the difficulty that we have at times to assess the severity of mitral regurgitation following the clip insertion. And another collaboration with another site in Texas, this time the Houston, Texas group, we were able to put together more than 150 patients at that point to assess the utility of what we call a vena contracta area assessment. In the functional MR, for instance, you see the crescent-shaped mitral regurgitation as a footprint of MR, if you will. That is essentially cropped into the jet that you see in the long axis on the right upper. The crescent shape speaks to the fact that MR is happening along the entire line of coaptation, and the vena contracta here is rather large with 1.3 centimeters. Now, this same approach can be used before and after the MitraClip procedure, and this publication that we got out in 2019 looks at actually 150 patients, I think, total in the analysis. And here is the methods approach as I just outlined on the previous slide. When we look at our results, we were able to not only demonstrate overall very good reduction of MR in our 155 patients, but we were able to also identify kind of a cutoff in our ROC analysis, as you see for the 3D vena contracta. And as you may appreciate in the small number, I enlarged it a little bit underneath. That cutoff for us, based on the vena contracta area, has now been 0.27 centimeters squared. If we have more than that, we usually are more inclined to some degree, if the pressure gradients allow, to add yet another clip to reduce MR further. If we are below that cutoff, then we are often quite happy to complete the procedure and say we've reduced sufficiently enough. This work actually has found itself in the post-procedural assessment guidelines that the ASE has published. So it's gone into some of that work. I'm going to take one moment to relatively quickly go through a patient who presented with an interesting pathology, an anterior leaflet prolapse. This is a 75-year-old patient with an EF that also was slightly reduced to 44%. The patient had a surgical repair of his aorta and therefore would be a redo surgical patient for a mitral valve surgery. Here are the initial images. As I said, 3D color helps us to describe and locate the origin of the mitral regurgitation. You see the en-face view on the left and the below the valve ventricular view on the right-hand side, again showing commissure to commissure jet in this particular anterior leaflet prolapse, so very broad-based prolapse, if you will. Again, the multiplanar assessment shows the crescent shape of the jet, and the vena contracta area in this example also exceeds 1 centimeter squared, while the PISA actually for this particular patient was 0.46 centimeter based on our baseline shift as you see it here. It's important to look at the pulmonary venous pattern at baseline under general anesthesia, and then again towards the end or after each procedural step. And we do appreciate significant blunting in this particular patient with a component of systolic flow reversal in the right upper pulmonary vein. Now, additional imaging during the procedure, first we approached this patient right in the middle of the valve with a large XTW, meaning a broad and long clip. That clip reduced the MR significantly, as you see on the right-hand side. The ventricular view, however, gives us a hint that the medial orifice of the medial remaining MR is more substantial than on the lateral side. So we ultimately, after quite some discussion and after assuring ourselves that the gradient and the mitral valve area were not prohibitive of further intervention, pursued another clip right next to the first one. Here you see the biplane imaging on the left, again, very helpful to use that tilt plane to be precise about the remaining MR. And if you look carefully, even on the right side image on the 3D enfase, you may appreciate that anterior leaflet prolapsing continuing to come up just above that clip, just medially from the clip as you see it there. So that was our target. We came in with the second clip. Often the second clip is easily aligned with the first one. And then if you come close enough to the first clip, then you can almost count on having both leaflets in as long as the first clip was placed well. So our grasp with now a NT clip, so small and narrow, because we didn't think we would have to do that much additional work, came in quite nicely. You see the clip being closed, and then the two clips very nicely adjacent to each other, giving us still a figure 8 for 2 ostia and not much of a further reduction of the mitral valve opening area, which at times is really important as well, as we don't want to create too much of a gradient. So the forward gradient for this patient in diastole remained at 2 millimeter mercury, a very nice result from that point of view. But then also looking at the pulmonary venous flow pattern, as you see on the right-hand side, quite convincingly now with systolic dominance on both right and left upper pulmonary veins as illustrated here. Again, it's important at times to look at the baseline under general anesthesia as you see it on the left, and then the post MitraClip therapy still under general anesthesia at this point, but that's really a fair comparison to look at baseline and then the effect of 2 clips in this scenario. If we were to flip that image on the right-hand side, the vena contracta for this particular patient at this point would be quite small and hard to appreciate almost. So the summary for this case, as one example, we certainly used 2 different clips, most of too narrow with the second clip, and we thought we had a very located pathology that we wanted to treat. The remaining MR was certainly no more than mild, and the ultimate reduction was very sufficient with normalization of pulmonary venous flow. Now, I'm going to take 3 slides here to go over a patient with a large P1 prolapse that you saw here playing for a moment, just to illustrate how even small changes in the perpendicularity or the orientation of the clip can make all the difference. This slide has moving images at this point, but the next one will show the moving clips in addition. But I just wanted to point your attention to the fact that in the middle column, D, E, and F, we have had a clip orientation of about 1 o'clock, 7 o'clock to treat that very dominant P1 prolapse that you see on the left-hand side column. Now, as you appreciate in the still image, even at the bottom under F, there's still a remaining PISA out of the commissure that certainly is hard to treat if we were to deploy this first clip right there. So what we did is we let go of that grasp and we moved to the right-hand column illustration, where we actually then turned the clip even further, as I say, 2 o'clock, 8 o'clock, in order to fully engage with the pathology and then have essentially no more regurgitation coming out of the commissure. So here are the moving images. Unfortunately, they're not moving very long, so I'm going to go back one more time and pay attention here. As you see at the bottom right, there's no more regurgitation coming out of the commissure once we have the clip in the perfect orientation. The final result for that patient illustrates, again, the 2 o'clock, 8 o'clock orientation that ultimately was quite successful. So again, small differences. One more case to illustrate the capacity or the opportunity for treatment, even in a large myxomatous changed mitral valve that has redundant and very long leaflets, both anterior and posterior here in the bi-leaflet prolapse. We can now, with the longer clips, reduce the height of such leaflets quite efficiently. And I'm showing that on the next slide. Right here, you see we use 3 clips now in this instance to align them really well with the medial commissure, and they're all dancing up and down in concert. They're still on redundant leaflets, as you can see there, but we have reduced the height of the leaflets, just like a surgeon would reduce the height with a quadrangular resection and a sliding ring annuloplasty. We're just not adding the ring, admittedly, but we certainly have reduced the height of the leaflets quite efficiently and got a great result in this particular patient. Next slide. Now I'm going to take one moment just to reminisce or kind of go back a little bit in history. And I know for those of you who've been involved in the MitraClip therapy right from the get-go, we did basically, and at that point I was actually still at Duke and started to be involved in the MitraClip therapy there a bit. We basically did initially almost everything based on short axis views on the left-hand side, as you see them here. They may not have been as clear as in this particular example, which actually is a patient that we treated about 3 weeks ago. And I just couldn't resist to show and share some of these images. Now that we have just now reached 500 MitraClips, it's interesting to kind of think back how we started. This is the baseline assessment for this particular patient, but now with nowadays technology achieving a larger 3D volume, I can not only appreciate the leaflets and the tethering in this functional MR situation. I see the papillary muscles, I see the cords tethered, and I really have a quite nice insight into the valve at this stage. So here on the left-hand side, we're looking from anterior. On the right-hand side, we're looking from posterior. Now, during the procedure, I continued to use some of the transgastric views, now adding the biplane component. As you appreciate on the right side of each of these images, we can now see the posterior leaflet on top and the anterior leaflet at the bottom. On the left-hand side, engage with the clip arm, so they make contact with the clip arm. On the right-hand side, you now start seeing how the grippers have actually come down, and they're starting to dance on the leaflets, showing that we've sufficiently sandwiched a large portion of each of the 2 leaflets. This next slide, we would have to watch the movie until the end, and actually, this is a very good reminder of my initial slide talking about the differences between the Alfieri stitch, the surgical placed Alfieri stitch in a flaccid heart, as opposed to the hemodynamic physiologic environment. Again, this is baseline. The clip has not been closed. Now Mark closes step by step the clip, and you see how the MR is essentially disappearing in front of our eyes. That is monitoring treatment right as we go. Now, there's some additional assessment before the deployment that we will go through in a stepwise fashion, looking at the insertions of the leaflet. We want to make sure the leaflets are immobile. And then we also chasing any remaining MR. The middle image, you see the tilt plane going through the clip. So we see the clip well on the right-hand image. On the right side image, You see I've moved the tilt plane into the remaining MR, and we can clearly see that the vena contracta width for that particular jet is not very large. Here are some final images for that particular patient with one clip in the center, two very equally sized ostia, both in 2D and then 3D. And if we add more depth to the 3D, you again see the tethered papillary muscles, cords, and the valve. And we should not underestimate that the clip actually adds tension to the entire mitral valve apparatus. Again, another aspect that we have been careful about not to adding too much. So for Mark's pleasure, I added various colors. He can pick his own color and take it back home or take it to New York as he gets on his journey. This is certainly an opportunity to look at the mitral valve therapy with the clip in a larger 3D volume, and I think the three-dimensional effect is quite pronounced. I didn't have time to go into many other structural heart interventions that we engage with. Here is just one example, is our approach to mitral valve disease when we have either a need for replacement of the mitral valve percutaneously or treat a previously surgically repaired mitral valve with a ring. And we have our imaging considerations that we developed along the way. And I want to mention Jim Kirkpatrick, who has been a great partner in this effort back when we put together this review. But it's again also essential for us to really be cognizant about the pre-procedural assessment and then the post-procedural assessment to get the most out of our very different perspectives. Now, not everything is easy, not everything is without noise. As you see in this slide, we have significant obstacles at times that we're dealing with. It's not just a pleasant work environment. There's pumps, there's alarms, and yes, we're still anesthetizing the patient. We need to certainly put into our understanding the physiology of the patient, which actually is a good argument for us as cardiac anesthesiology trained physicians to be there, because we can put those things quite well together. We can work with the ventilation in case we need to hold it. But yes, we are all exposed to the radiation, and we're constantly working on optimizing some of those caveats and obstacles. Now, when I take one moment for a take-home message, and this is work we've done as a task force at the ASE, which now has evolved into a specialty interest group for interventional echocardiography. And we just formed also a task force to think about the training that's needed for this type of interventional echocardiography. These words came up. So you need to think about the mitral, your target. You need to trust your partner that you work with. So in this case, the interventional cardiologist, be it Jamie McCabe or Creighton Dawn or Christine Chung, who just joined us, or Mark Riesman, they need to trust that the images we bring up really reflect reality and that we're not making something up. The communication is key. That showed up here in this word cloud as well. There needs to be respect, reward. I think those are important aspects. And with that, I'd like to just summarize that I believe it's really important to have a stepwise approach to this type of image guidance. So you need to be organized. We need to use all our 2D and 3D skills in order to optimize, constantly optimize the image. I'm of the opinion that every image can always be optimized. Therefore, we need to strive for excellence in imaging, to work out all the details, always thinking ahead of the next procedural step. Again, communication is key. We need to talk to each other, not above each other. And then real-time multiplanar imaging will continue to revolutionize the procedural image guidance as I see it. That is that example of the best of both worlds, the multiplane on the 2D that is educated by having a high quality 3D image. And as we all aware, unfortunately, Mark has decided to go back home. So I thought I'd bring in a few images that illustrate teamwork. And I realized that not the entire team is pictured, but this is after a TCT live case there's a number of representation from the cath lab. There's Dimitri Levin and my colleague Richard Chu. And then also a CRNA that is of great support in all of these live cases, Lang Conte. In the middle, you see Mark and myself doing something dangerous before COVID without a helmet. So be careful on these Lime scooters. And then at times, Mark needs to rest. And here he rests on the image intensifier. And I'm glad to say that we have converted Mark into an ASE member. You see his hat. He's a strong advocate of echocardiography. I think there's very few in this country that will put as much value to imaging as Mark is. So thank you for that, Mark. And with that, I conclude and thank you for your attention.